in the next 8 minutes or 10 minutes, I'm going to be talking about interventions for resistant and hypertension. And this is a very interesting topic. So let us just quickly go through the different epidemiology of hypertension. And I'm sure this slide must have been sort of shared earlier as well. If you see world over, about 1/3 of the hypertension patients are untreated. About 1/3 are treated, but they are not well controlled. And only about 1/3 are treated and well controlled. It is also very interesting to see that every 20 millimeter systolic or 10 millimeter diastolic increase in blood pressure correlates with doubling of 10-year cardiovascular mortality, and it dramatically increases the risk of stroke, heart rate, heart failure, and kidney failure. And only, there is a very high prevalence, and in world over, we have about 1.6 billion people who would be suffering from this disease by 2025. Okay. So what we see here is, again, the same thing. The cardiovascular mortality almost doubles by just increase of blood pressure by 10 millimeter of mercury. In the meta-analysis on cardiovascular mortality, it was seen that this is from 61 prospective observed studies, and it was seen 10% reduction. It was there observed in the risk of stroke and 7% reduction in risk of ischemic heart disease by only 2 millimeter reduction in the office systolic blood pressure. So we can understand how important it is to control this blood pressure and how difficult it is to actually achieve the targets in the real world population. Again, these are the breakdown of different causes of uncontrolled hypertension. Dr. Dayasagar Rao, Dr. Sunil Modi, and other speakers have actually talked in detail about it. So I'm not going to be talking about it. But if you exclude all these other causes of uncontrolled hypertension, then comes the cause, a real cause, which is a true resistant hypertension, where 4 or more drugs actually fail to control the blood pressure properly. Now, if you look at the failure of current approach, pharmacological approach to successfully treat hypertension, it varies from 29 to 53% world over. And these are because of various mechanisms, and I'm not going to be going in detail about it. The topic is restricted to interventional treatment. The most common treatment which we do is if you have young children with coarctation of aorta and they have hypertension, many a times if you treat and relieve this coarctation early, the hypertension actually gets better controlled, but rarely cured. And many patients would have renal artery stenosis, and if we can timely dilate and stent these renal arteries, then these patients can do well in terms of control of blood pressure. So I'm not going to be specifically talking about these two interventions because this is done very routinely and everybody knows about it. The other conditions where renal arteries can be involved is non-specific aortoarteritis in fibromuscular dysplasia and IgG4 immunopathy. And with there again, renal artery stenting comes or angioplasty comes in big role to control hypertension in these patients apart from the medical therapy. Now, there has been a lot of controversy about the role of renal artery stenting, especially after the Astral and Coral trial. And what has emerged out of the data is routine renal artery stenting in a hypertension patient does not help. The way to predict whether it's going to help or not is to do a selective renin sampling from each renal veins and see if the selective renal, there is a selective hyperinemia from that sample, then in that situation, the renal artery stenting may help. Otherwise, if there is an uncontrolled hypertension with 4 drugs in good doses with renal artery stenosis, again, that's an indication for doing renal artery stenting, provided the stenosis is more than 70% and the gradient is more than 20 millimeter of mercury. And these days, a lot of role has come in using FFR for renal artery stenting. And the FFR cutoff value here is 0.8. So, and the third classical indication is if you have a hypertensive patient who goes with renal artery stenting, who goes into who goes into recurrent pulmonary edema, again, this patient requires definitely it's class 1 indication for renal artery stenting. And if patient has a bilateral renal artery stenosis or a transplant-related kidney which has stenosis with hypertension, this requires renal artery stenting. So now the newer interventional therapies are renal denervation, which was which came with a big, hope and hype initially, but then it went into disrepute, and again it's coming back. We also have barostimulation devices and also ROX couplers and carotid body ablation. So I know there's a talk after this about renal artery sympathetic denervation, so I'm going to be quick and not talking much about it. The sympathetic nervous system supplies catabolic signal to the body, acting whenever rapid response is needed. And this response also includes hypertension. Now, sympathetic system is the key driver for hypertension. It leads to renal artery vasoconstriction, sodium fluid retention. It enhances the renin release and also stimulates systemic sympathetic response. And all these four factors are important in producing resistant hypertension. Now, if you see this, there is a sympathetic activity. If you see sympathetic activity per minute in any class of hypertension, right from normotensives to high normal blood pressure people to hypertensive, borderline hypertension, and all stages of hypertension, you have what you see consistently is that there is a higher sympathetic activity per minute in these patients. And this is not a new knowledge. This was not known at least 90 years ago, when classical works were done and published in different journals from Harvard Medical School in 1931, and also by Dr. Smithwick, and he did a series of 1,366 surgical splenectomies for essential hypertension, and there was a good relief, and also in 1952, which was published in the British Medical Journal. So this used to be a good surgical technique to control hypertension when the good drugs were not available. But then good drugs came, and the newer insights came in medical therapy of hypertension. And this concept was maybe forgotten for a long time, till we had an interventional device which could selectively ablate the nerves which are present in the adventitia of the renal arteries, and this would decrease both the afferent and efferent decrease or ablate the afferent and efferent pathways of the central nervous system supplying the renal nerves, and this would decrease the central sympathetic activity and decrease the blood pressure. And this is a diagrammatic view where the sympathetic nerves are present in adventitia. And that is why many catheters were designed to deliver a radiofrequency energy to ablate the nerves in the sympathetic nerves are in the renal artery. The first study which was done by a Medtronic, through a Simplicity catheter. And it was a very simple catheter with just one point for ablation, and this was rotated, and it was in a spiral form and pulled back, and this ablation was completed in 4 to 6 minutes. This is one of our patients, which we did probably for the first time in the country. It is simple to do, but there is no control. There is, of course, a safety mechanism built in the machine. The results were variable, and what it does histologically, it sort of stimulates, and there is a destruction of coagulative destruction of the sympathetic nerves in the adventitia and also in the periadventitial tissue. This study was done first as a first-in-man study, and then larger studies which were known as first-in-man Simplicity Hypertension 2 and Simplicity Hypertension 3 US randomized clinical trial, which actually turned out to be a negative trial, and it was seen that there was no benefit in doing this sort of a procedure. Although it was a conventional and intuitive thinking that this procedure used to work in surgical patients. So that is why it was sort of revisited, and different type of catheter designs were made so that the ablation could be more circumferential and it could be more complete, and also that we could avoid injury to the vessel, other parts of the vessel. We can have a simultaneous cooling of this renal artery at the time when we are giving radio frequency energy to ablate the adventitial nerve. So now it's coming back. So we have a device from Covidian which has a simultaneous cooling, which is balloon based to center this catheter, and also we have a new electrode from Medtronic, which has helical and elliptical electrodes, which is working. So apart from this, there is other way to actually control blood pressure is, that we have, the baroreceptors at the carotid bulb. If we can somehow dilate it mechanically and keep it dilated or stimulated, in both ways, we can actually give stimulus to the brain that the pressure is high at that point, and this will lead to a counter down regulation of sympathetic stimulation and decrease the blood pressure. So we have implantable devices which sort of stimulate and the baroreceptors in the carotid, and we also have self-expanding stents in the carotid for amplification of baroreceptor response in these patients. So we have this device which is known as the Mobius HD device from Vascular Dynamics. It comes in 3 sizes from 5 to 11.5 millimeter in diameter, and it is placed in a very easy way in the carotid bulb, and it stimulates and reshapes the carotid bulb, leading to a fall of systolic as well as diastolic blood pressure. 9 patients have been done up till now by these devices, and it has been shown that there was a clear reduction in medication, the number of medication, and also the dosage in these patients. And the safety, there was no safety issues, and the distal protection devices were not. The last device is Rauch's coupler, where we create a 4 millimeter arteriovenous anastomosis in the iliac or femoral veins. And it is seen that this is in a non-sham procedure that it drops the blood pressure by 30 millimeters of mercury. And it has a controllable shunting mechanism. This has not been approved by FDA, but it is there for investigational use. And I'm sure in future this will also be a very simple device to actually treat resistant hypertension or malignant hypertension in patients. So the rocks. So I've just told about this rocks coupler. There have been trials which are going on these rocks couplers, and it appears to be a very, very prudent device. Now, these sort of courses we do. This is the Asia Pacific Vascular Interventional course, where we talk about mechanical and interventional procedures, and we do workshops for not only interventional procedures for hypertension, but for various other vascular disorders. And this has grown to be the largest endovascular course in the entire Southeast Asia. And I would welcome all of you on the last weekend of June this year for our 13th session of this meeting. Thank you very much.